Well, without any further ado, I'm very happy to welcome Dr. Caludette Adegboro, an assistant professor from the Department of Pediatrics here at UW. She received her Bachelor of Arts in Africana Studies from Johns Hopkins and a medical degree from Ross University School of Medicine. She went on to pediatrics residency at Mount Sinai Children's Hospital in Chicago and neonatology fellowship here at UW before joining faculty. She's the physician lead to the Peri-Viable Infant Project and the maternal fetal medicine liaison to the Division of Neonatology and Newborn Nursery. Her primary research interests lie in preventing neonatal brain injury and improving neurodevelopmental outcomes among extremely premature infants. She's also passionate about educating others on racial inequalities in healthcare, in particular with a goal to root out disparities in mortality among Black and white infants, in addition to advocating for breastfeeding equality. Please join me in welcoming Dr. Adegboro this morning to talk about viability.
Thank you so much for that introduction, Laura, for Dr. Bizzuto. Can everyone hear me?
Yes.
Awesome. And can you see my slides?
Yes.
Great. Okay. Well, thank you for joining me this morning. And as Dr. Bizzuto said, I am one of the NICU docs here, and I am joining you guys today to discuss an increasingly important topic in obstetrics in both the field of neonatology. And what we're finding is that in both obstetrics and neonatology, the obstetric interventions and active resuscitation, respectively, for extremely preterm infants at 22 to 25 weeks is a practice that's rapidly developing. Survival rates and outcomes are markedly improving for these babies day by day. And that's not just in the United States, but in several countries, including Sweden, Germany, Japan. So adopting this clinical approach here locally would afford our families a tremendous benefit in patient care. And it would also help us gain recognition as a cutting-edge center of excellence in the care of tiny babies. So with that said, I'd like to start by saying that I have no financial or other disclosures, and I have no actual or potential conflict of interest in relation to this program and presentation. My goal today is to start by taking you through the literature surrounding our current practice and explore survival and outcomes for these tiny babies, and then move on to briefly discuss the steps that we're taking to change our own culture and practice here at Meritor to become a more unified team dedicated to the care of these extremely preterm infants. One of the first things that I want to do is just show you guys where we stand in our policy. And this is policy 188. And policy 188 is at present our current guideline for birth and care and resuscitation surrounding extremely preterm infants. This document was created in 2001, and it states that it will be our practice to resuscitate all infants who have decided, or excuse me, who have reached a gestational age at 23 weeks and 0 days, unless there's a plan not to. And this would be following a consultation with parents and the maternal provider, MFM, the NICU doctors, and then it would be up to the maternal providers to notify MFM and neonatology for consults, to discuss with the parents about their choices and options, document all the decisions that would be for the delivery room resuscitation. And then the MFM and NICU docs would then also document their consultation. But there's an added recommendation that the neonatologist will be present at the time of birth to validate the quote unquote viability or the appropriateness of the resuscitation, and then guide the resuscitation team in the best interest of the infant. But there's an important question here. Is it at this moment at birth to decide whether the infant is viable? Is that the best time? Well, better and more current practices suggest that the answer to this question is a hard no. In addition, there are currently no recommendations prior to 23 weeks surrounding obstetric interventions and active NICU care for these infants. And as a result, the NICU and MFM teams set out to include more specific recommendations for active intervention beginning at 22 weeks. And we're also aiming to meet with families jointly and, most importantly, standardize our practice, as this will be paramount when providing optimal care for these extremely preterm infants. Another thing to mention before we begin our review are the additional recommendations that we've agreed upon between our two groups. And so this slide details our joint efforts to support obstetric interventions and active resuscitation for periviable infants, or nanopreemies, as we have started to affectionately call them. I'll ask you to hold your questions, though, on this slide, because we will revisit it later and explore in a bit more detail. So when we talk about the definition of what viability means, what exactly does being viable mean? What exactly does it mean to be periviable? Well, the Webster definition of being periviable is capable of living, or being capable of living, capable of surviving outside of the uterus, or has the potential to grow and develop. The National Institute for Child Health and Human Development, the American Academy of Pediatrics, and the American College of Obstetricians and Gynecologists, going forward, that we'll refer to as NICHD, AAP, and ACOG. They all got together in 2013, and they created a joint workshop to discuss the management of periviable birth and care of the extremely preterm infant. So the product of the workshop was this executive summary. And the executive summary, surprisingly, at the time, showed that there was a lot of variation among the gestational ages. And there was also variation in the way that we practice, and the way that we gave obstetric interventions, and the way that we provided active resuscitation, or the lack thereof. So an important takeaway from that actual joint workshop and the executive summary was that we need to standardize our care and confer as obstetricians and neonatologists prior to meeting with the family whenever possible. During the meeting, they also defined what periviable birth meant. So that was a delivery that could take place anytime between 20 weeks and 0 days and 25 weeks and 6 days. So at present, the limit of viability at many centers in this country is emerging as early as 22 weeks. And again, as first described during that joint workshop, researchers are finding that survival rates are greatly influenced by the center's local protocols or obstetric interventions, as well as our NICU measures. And so the initial assessment of viability comes from the help of our obstetricians. Typically, gestational age can be assessed within the first 7 to 10 day window, or within a 7 to 10 day window. And gestational age can be determined by the last menstrual period, the bimanual exam, early pregnancy tests, first trimester ultrasound. But it can be hard to be accurate about what exactly 24 weeks means, when 24 weeks can equal 24 weeks exactly if dating is based on IVF. There's a wider margin if dating is based on first trimester ultrasound, somewhere between 23 and 25 weeks. And there can be an even wider margin of 22 to 26 weeks if dating is based on the last menstrual period. So there's really no other time during pregnancy where these windows will have a higher impact than during the periviable period. So one of the other things to talk about is the obstetric care consensus. And so following that joint workshop in 2013, members of ACOG and the Society for Maternal Fetal Medicine reconvened to create this obstetric care consensus. And here they reviewed current literature at the time and provided an interim update on the recommendations that we should follow in the practice of periviable birth. And so within the update, they recommended best practices to improve our outcomes of the births of extremely preterm infants. And so this included transport to a level 3 center where the mother could give birth, and advice and recommendations on short-term and long-term neonatal outcomes as well as maternal outcomes. And then more importantly, the concept of creating a detailed delivery plan with the family that's recognized as a general plan and can be modified based on how the clinical situation continues to evolve. So this is an article from James Cummings, who was one of the authors of the obstetric care consensus and was involved in that executive summary. And he sits on the chair of the AAP committee of the fetus and the newborn. And he published this really nice report highlighting other key points from the 2013 joint workshop. And the goal of the report was to provide providers effective counseling and managing for periviable births. An important point that stood out from the report was that at 22 to 24 weeks, outcomes can vary and are quite difficult to predict. And a more important point, that there was a pretty noteworthy quote in the report that makes a direct reference to that policy 188 concern that I mentioned earlier in the presentation about assessing viability on the spot. And the quote reads, "Some physicians recommend a wait and see attitude, suggesting that a skilled resuscitator be present at the delivery to intervene should the infant appear quote unquote viable at birth. However, such decision-making in the delivery room delays the initiation of resuscitation and is prone to error. When experienced neonatologists viewed delivery room videos of extremely preterm births, their ability to predict survival was no better than a coin toss." And I think that statement is so key in reshaping our approach to the way that we care for these extremely preterm infants. I think it's also important to recognize that our attitudes among all providers vary. And it's going to be important for us to use our local institutional outcome data to help us communicate mortality and morbidity to our families. Additional guidance and recommendations from the obstetric care consensus focus on the obstetric interventions for threatened periviable birth. So in 2016, when these guidelines were first formed, committee members agreed that the available literature provided strong recommendations with a high quality of evidence against providing obstetric intervention for periviable birth at 22 weeks. But the interesting thing about this is that there's a weak recommendation with moderate quality evidence to provide resuscitation for infants at 22 weeks. So it's worthwhile to note that without obstetric interventions like the antenatal corticosteroids, the outcome for periviable infants would be extremely poor and mortality would be virtually 100%. And so the antenatal steroids, it's a highly valuable and very essential obstetric intervention that's required in order to drastically improve our mortality rates. Danielle Arrett, a neonatologist from the University of Vermont, looked at the effect of antenatal steroids on survival rates among infants 22 to 25 weeks gestation. And she found that survival following the administration of antenatal steroids, whether it's partial or complete, markedly increased survival rates. And just to orient you to this table from her study, on the far left is the gestational age in descending order. So starting at 22, 23, 25, 24, 25 weeks, and then the composite of 22 to 25 weeks. And what you can see is that survival with the use of antenatal steroids doubles at 22 and 23 weeks. And that statistically significant relationship continues at each gestational age, though the margin is a bit more narrow of improvement. Still, it's quite incredible what the advent of postnatal steroid or prenatal steroids can do for survival in these extremely preterm infants. There are also several other studies that have identified that the use of antenatal steroids can also reduce necrotizing enterocolitis, severe intraventricular hemorrhage, and death, and that it improves lung maturity and reduces respiratory distress syndrome. also reducing the incidence of neurodevelopmental impairment at 18 to 22 weeks or months. Here I included this key study from Helene Norberg, who is a Swedish pharmacist, as well as Mikael Norman. He's an internationally recognized neonatologist in Sweden and a leader in the care of extremely preterm infants. And these authors use the Swedish National Express database to surveil about 600 infants exposed to standard doses of antenatal steroids. And Norberg and Norman found that if any antenatal corticosteroid were given prior to birth, and I do mean literally any, even within an hour of birth, there was a pretty significant association with increased survival among extremely preterm infants between 22 and 26 weeks of age, versus whether there was no antenatal corticosteroid given. So this effect, of course, was greatest if antenatal corticosteroids were given at least a day prior to delivery and up to 7 days prior to delivery. Pretty important and a second and vital aspect of interventions needed to improve periviable infant survival, specifically at 22 weeks, is the decision of whether to provide a cesarean delivery for fetal indication. So currently, the recommendation is that cesarean delivery would not be offered prior to 23 weeks for fetal indication. It would only be offered for maternal indications. And so this is also in the setting of malpresentation. There are publications over the years that have stated and encouraged that we avoid cesarean delivery for fetal indication at 22 weeks. But these recommendations are outdated and are not necessarily based on any evidence. And so given that the advent of obstetric interventions has improved, or the advent of obstetric interventions and as well as neonatal resuscitative measures have markedly improved, newer studies are actually showing that there's a marked benefit and improved survival for periviable infants following cesarean delivery. And so in this study published just actually earlier this month, from Robert Rossi's group at the University of Cincinnati and his trainee, Heather CZARNY, who is a Wisconsin native, no less. The authors actually showed that cesarean delivery at both 22 and at 23 weeks markedly, or the infant survival at 1 year of life was markedly increased following, and statistically significant, I might add, following cesarean delivery. So there is some controversy in the literature about whether to proceed, and I think this is still an unfolding process, but the current recommendations that we saw from the obstetric care consensus says that we should not proceed with C-section at this time, but I think this is an ever-evolving process, and there's more to come where this is concerned. So why don't we transition now to our world, Babyland, and we'll discuss some new and exciting things that we neos are seeing in the literature, given the obstetric interventions you guys, our colleagues, are giving to the mothers. So this is the Tiny Baby Registry, and the Tiny Baby Registry was created by neonatologists at the University of Iowa. And the site serves to offer a detailed registry or a detailed list of babies born at the earliest gestational age all over the world. Currently, there are about 283 former preterm infants in the registry, and there are about 3 babies that were born at 21 weeks gestation and about 24 babies that were born at 24 weeks gestation. 22 weeks gestation. So please keep in mind that this is in no way an exhaustive list of every extremely preterm infant that was born in the world and the history of the world even. But it's just a really nice resource for parents and providers to reference as far as who these tiny babies are and if they are still thriving. This is baby girl Stensrud. She was born at 21 weeks and 4 days. weighing on higher weight for gestational age of 410 grams. And on the left, we see her at 3 weeks in an incubator at San Antonio, or it's called the Methodist Children's Hospital in San Antonio, Texas. And then on the right, we meet her again at 4 years of age, and she is clearly ready for the beach. So these are, beautiful pictures of just growth stemming from 21 weeks. So she was a bit of a larger size. So this one is Richard Scott William Hutchinson. That's a very robust and stately name, I might add. He actually is considered to date the youngest baby born alive at 21 weeks and 2 days. And so he was born last summer, actually, at Children's Minnesota. And on the left, he's pictured and incubated within the first week of life at 340 grams. And on the right, he is 1 year of age and having fun with his smash cake. So these images that I'm showing are important not just because they are awesome success stories, but rather because they speak to the fact that our current practice is changing, and that's across the nation. So we're not saying that these infants are without any form of medical complexity, because as you can see, William has a nasal cannula at 1 year of age. But one would argue that it's becoming somewhat criminal to not resuscitate these infants, given the advent of the number of obstetric interventions that we have nowadays, and given the amount of resuscitative interventions we have from the neonatology side. And on top of that, our survival rates are improving all over the world, and our neurodevelopmental outcomes are reaching near normal in several places. So in the US in 2018, there were 4,340 live births at 22 to 23 weeks. That year, in 2018, the number of infants born in the United States was about 3.8 million. And so that, just doing some basic math there, that would give us an incidence of about 0.1%, or 1 in 1,000 births. Now, surprisingly, that's the same incidence as infants with fetal alcohol syndrome, or infants with Down syndrome. And those are two diagnoses, both of them, that a provider and most parents nowadays would hesitate, if ever, to consider pregnancy termination, or let alone withdrawal of care. And then also keep in mind that infants born at 22 weeks account for about 14% of infant deaths, or 1 in 7. So a few months ago, our group had a chance to meet with Dr. John Daigle, who is part of a group at the University of Iowa who have become international leaders in the care of extremely preterm infants. And Dr. Daigle provided us a bit of sage knowledge and insight for our group. So he presented a couple concepts. The first one being the notion that no one seems to like preemies. And this is a statement that was born out of an article by Anne Handier that was published back in 2008 that looked at providers, including NICU providers, attitudes towards resuscitating 24-weekers. And what they found when they surveyed several physicians, including actually asking what specific scenarios would you provide resuscitative efforts for? And on that list were infants who were, there were 14-year-olds or 35-year-olds with a brain cancer who only had a 5% chance of living, or individuals with life-altering or fatal diagnoses. And out of 8 different scenarios, where a 24-weeker had a 50% chance of living, most providers would only resuscitate a 24-weeker ahead of an 80-year-old man with dementia who had stroke. I mean, it was pretty shocking to recognize that we as providers had this bias of whether or not we resuscitate these infants at 24 weeks, despite the fact that they had a much higher survival rate than a lot of these other individuals who had terminal illnesses. And so another relevant concept that Dr. Daigle shared with us was how we view care of these infants in the United States. And of all things, we do not have a scarcity of resources in the United States to provide care for these babies. And so when we talk about how much is spent on neonatal care in the United States, back in 2005, because it's a bit older data, but it drives the point home all the same, but we spent about $17 billion on neonatal care. That year, we also spent $14 billion on pet food. And that's just the food, not necessarily healthcare with the veterinarian or anything of that measure, but just pet food. And for the NFL, we spent about $13 billion. For video games, we spent about $13.3 billion. And then in more recent times, in 2011, we spent about $53 billion in 1 year on cosmetics. We also spent about $18 billion on fantasy football. And so it goes to show you, as Dr. John Daigle would say, that we spend more money on fantasy football than we would an actual human the size of a real football. So I think the point to drive home here is the fact that the amount of money we spend on random things outside of just basic basic care goes to show you that if we're not willing to spend $17 billion on neonatal care, are we really valuing, or have we devalued the medical care of these infants? One big issue, though, in caring for these extremely preterm infants is our consistency in practice. And so this figure is from a landmark study done by Matt Rasavi, who was a pediatric resident here at UW some years back. And Matt has also become internationally recognized for his care of extremely preterm infants, and he's joined the group over at Iowa. Edward Bell is another author on the paper who's pretty noteworthy as well. And so what Matt and Dr. Bell showed in this study was that we NICU providers, as I said before, are quite variable in our active resuscitation and the care that we provide these infants. But it's not just locally, it's on a national level. And so the differences in our practices explain a large portion of the between hospital variability in the survival of these infants with and without severe neurodevelopment. And so the rates of active treatment account for about a 78% variability in survival rates for these infants at 22 and 23 weeks. And this number drops down to 22 at 24 weeks, and then further to 25 at 25 weeks down. It doesn't seem to create an appreciable effect. But what you notice too is survival without severe impairment is also similar, respectively, between 22, 23, and 24 weekers. And so this just goes to show you that the variability in our practice can significantly affect the survival of these infants. And then this is just a table that I put together to kind of simplify things to show you what we saw in the previous slide. I mean, it really is just unbelievable how variable our outcomes can be depending on the hospital rates of active intervention and resuscitation. In 2017, Ravi Patel and Matt Rasavi collected data from the NICHD Neonatal Research Network, or the NRN, for periviable live births. And I'll go over approximately, we say, a 22-year period. They saw that the survival rates at 22 weeks was essentially plateaued. There were significant increases in survival rates between 23 and 24 weeks, and then incremental increases at 25 weeks. But this is more recent data from Matt Rasavi's publication in Immature Science. What it highlighted in 2019 was that up to 58% of infants born at 22 weeks received active treatment. So things are changing. And about 29% of those infants actively treated actually survive, right? And so those numbers are pretty impressive. I mean, what it says to me is honestly that if we just try as two teams, combining our efforts, that we could potentially save so many lives. And so what's happening in other countries? Well, in Sweden, I mean, as back in 2015 to 2016, they were seeing survival rates as high as 50%. In Japan, again, back in 2015, they were seeing survival rates at 22 weeks gestation as high as 65%. And their neurodevelopmental outcomes are also pretty impressive. This is a study from Carl Backus at Nationwide Hospital. He's another neonatologist that's prominent in the care of pre-viable infants or extremely preterm infants. And what he did was compare his center at Nationwide in Ohio, which is a selective center, with another international center in Uppsala, Sweden. And the two centers, the difference between the two of them is that Nationwide at the time was a selective center where, based on the physician preference or the parent preference, they decided whether they would offer antenatal steroids, whether they would perform active resuscitation or active NICU care. But Uppsala, Sweden standardized their care, where all 22 weekers, if parents requested, were offered or not necessarily if parents requested, but all 22 weekers are offered the ability to have antenatal steroids, active treatment, and active resuscitation. He evaluated the outcomes of these infants from 2006 to 2015. And of the 112 live-born infants at 22 weeks, what he found was that the survival rates at his center at Nationwide in Ohio was 7-fold lower than the center in Uppsala, Sweden, which was a standardized care practice or offers standardized care. And even when they looked at survival to 1 year following proactive care, meaning that the selective care then said, hey, we're going to standardize our care and then we're going to provide care to all 22 weekers. What they found here was that there was still a 2.5-fold difference at the center in Uppsala, Sweden, that started as a standardized care center versus the selective center that then became a standardized care center, suggesting that, providing these consistent and standardized care approaches are certainly superior than asking each time whether or not we want to resuscitate. This paper is from the University of Iowa. Again, a center that has become internationally recognized for their care of extremely preterm infants. And in 2020, they published a pretty landmark article about their outcomes following decades of standardized obstetric intervention and decades of standardized active resuscitation for infants born at 22 to 25 weeks. And the data not only shows their impressive survival rates, but also their excellent neurodevelopmental outcomes over the last 10 years. And so what we see is that at 22 weeks, these infants, about 70% of them survived. And then of the infants that were available for evaluation of neurodevelopment, at 18 to 22 months, 55% of them had near normal development or no or mild neurodevelopmental impairment. Even when Rasavi and his mentors looked at the NICHD NRN, they looked at infants between 22 and 27 weeks and compared their neurodevelopmental outcomes among about 6,500 extremely preterm infants. They found that still those numbers were anywhere from 50 to 60%. So that it's not just Iowa that are changing their practices. This is different centers around the country that are changing their practice and pushing themselves to improve their outcomes among extremely preterm babies. And this is just showing you that death and survival to discharge at Iowa were also pretty remarkable, with very low survival rates at each respective gestational age. This is an additional slide from Dr. Jonathan Klein, another neonatologist from the University of Iowa, who's played a vital role over the last 30 years in their success. And here they compare Iowa's survival rates of extremely preterm infants at 22 to 24 weeks to different centers throughout the United States, as well as internationally. And what we see is that at each gestational age, 22, 23, 24 weeks, the numbers at Iowa far supersede the numbers at other centers in the US and other centers in the world, actually. So in summary, we've learned from our introduction and review that gestational age is imprecise, but 22 weeks is becoming the lower threshold of viability. Obstetric interventions provide life-saving measures and can drastically affect survival rates and outcomes for extremely premature infants at 22 to 25 weeks gestation. Their global survival rates and outcomes for extremely preterm infants at 22 to 25 weeks gestation have markedly improved, and local outcomes for periviable infants will only improve if we standardize our practice and provide consistent, timely, and combined efforts. So I think a last question that we need to answer, though, is given this plethora of information, what have we decided to do with this, and how have we accepted the call as a group? Well, first, it's important to review our metric data and to understand where we'll start our journey with this. So this table represents our mortality rates here at Unity Point Merida, courtesy of the Vermont Oxford Network, or VON. And our local, it's also using our local maternal and infant database, PERI data. One thing important to note is that the denominator also includes stillbirth data. Susan Carmichael published a paper expressing that the value of including stillbirth data in your survival rates is quite important, because about a third of infants between 20 to 25 weeks that can be attributed to stillbirths. And so it's important to diminish the variability and inaccuracies that we see in survival rate reporting, and to understand why we have periviable births by including stillbirth data. And so with that said, what we saw was that our mortality rate at 22 weeks was virtually 100%. The number does go up to 53% at 23 weeks, but certainly room for us to improve. What is critical to note, though, is that our metric data at 24 to 25 weeks, when antenatal steroids are offered to nearly every infant, drastically changes, and our survival rates shoot up to 70 to 95% on average. And thus far, to the best of my knowledge, we have yet to perform a C-section at 22 weeks for fetal indication. And so how do we improve our survival rates for the tiniest of babies? Well, that 2016 obstetric care consensus on periviable birth that we discussed earlier does advise that we as obstetricians and neonatologists follow practices that can affect our clinical outcome. And for obstetricians, that is offering antenatal steroids, tocolysis, antibiotics, for PPROM, magnesium sulfate for neuroprotection, and determining the site and mode of delivery for these infants. For the NICU doctors, initiating resuscitation and subsequent care approaches to ventilation, such as optimizing ventilation and oxygenation, and optimizing our nutritional support, and very critically, and being vigilant, very critically screening for sepsis and being vigilant about that process. So again, this is our policy 188, as we saw earlier. And these are the additional recommendations. The slide I showed you earlier, and I promised to show again. And essentially, these additional recommendations are that maternal fetal medicine and NICU should confer and have joint consultation with families to improve our care and survival rates for these extremely preterm infants. Our prenatal efforts, as well as our resuscitation efforts on the neo sides, need to match. It's important that we discuss discrepancies in weight, fetal anomalies, maternal health, issues with maternal infection, or inaccuracies in dating. And then always offering a palliative care conversation if requested or if advised. So it's important to note that this is not an opt-out decision that we're providing for parents, but rather we're honing our skills and formalizing the process so we can offer excellent care. The second is to do everything in our power to support these families who do request resuscitation before 23 weeks. And that includes we, the NEOs, offering resuscitation beginning at 22 weeks and offering antenatal steroids as early as 21 weeks and 5 days. We met jointly with our MFM colleagues and agreed on recommendations for intervention and resuscitation of extremely preterm infants. And of note, to encourage a 48-hour window of antenatal corticosteroids and the administration of them, we asked that obstetric interventions begin as early as 21 weeks and 5 days. Now, though the suggestion is to assess the infant at 22 weeks and 0 days, if it's such that there is imminent delivery and within that 48-hour window, that's still something that we need to decide on a case-by-case basis, at least for the time being, for these infants when we come together to provide obstetric intervention and resuscitation. And then the decision on whether to proceed with cesarean delivery is still controversial, but the literature is actively changing. And so this will be a recommendation that we'll need to tease out a bit more in the future. Regarding some of the things that we're doing in the NICU, we've created a parent information sheet that details the differences in survival and care for infants 22 to 25 weeks gestation. And so this information sheet will be placed on cardstock and circulated with our book, Expecting a Preterm Infant. When counseling parents, we also use the VAUGHN birth outcomes tool, which does a better job of providing up-to-date, more center-specific survival rates. So for instance, when we plug in our data here at Meritor, hypothetically at 22 weeks, infants that are not actively treated, the survival rate is about 17%. But then hypothetically, if we provided active treatment and obstetric interventions and resuscitation and whatnot, then that number would double, which, you know, essentially says that it's really important to develop consistent and agreed upon strategies for threatened periviable births. And finally, this slide shows what we've been working on when it comes to improving our practice of extremely preterm infants. And we've been doing this for some time now, over the last 5 years. You know, certainly this is not an extensive list of everything that we've ever done in the NICU, but it does give some nice highlights of some of the things that we've done to prepare for our tiniest of babes. And so you can see that in 2016, we started with the use of the transport ventilator to move neonates from the delivery room to the NICU. And we have been providing this, care for these tiny babies for quite some time. The following year, just based on the current literature, we decided to look into the golden hour concept, where we would try to establish ventilation, establish IV access, and give choice medications within the first 1 hour of life. With that, we also worked hard to get our umbilical line placement down to the first 1 to 2 hours of life. And then in the spring of 2018, we implemented the micro-preemie care guidelines, where we paid attention to the PEP to try to stent their lungs open a little bit better, worked on maintaining ventilation ahead of schedule or ahead of time. And then we worked really hard to have universal delayed cord clamping, which was championed by our division chief, Dr. Ryan McAdams. And then in December 2018, we made sure that there was automatic surfactant administration given to our infants who were greater than 25 weeks gestation, which has certainly improved our outcomes. In 2019, we implemented the microcleaning manual, which is a nice little handbook that we give to our staff and trainees. And then just last spring, we acquired the jet ventilator, which has been pivotal in providing resuscitation or very good ventilation for these infants. And we've met with local leaders in jet management to really improve our skills and make sure that we are well-versed in the use of the jet ventilator. And then just this spring, we met with some national leaders in the care of infants less than or equal to 23 weeks gestation, and learned a bit more about how we can improve our care. And we are creating guidelines on anything from ventilation to skincare, which might not seem like a big deal, but skincare can be a very big deal for a baby born at 22 weeks that has underdeveloped skin. And then just a few months ago, we moved to go forward with our interdepartment agreement to offer obstetric intervention and active resuscitation as early as 22 weeks. So with that said, I want to take a moment to just acknowledge all our neonatology providers. I do have the honor of working with an amazing group of neonatologists, and they never fail to push the envelope, and they provide cutting edge care and treatment to our patients. And, you know, a couple of years ago, we saw a concern and we quickly met as a group to brainstorm about that and develop a consensus amongst ourselves. And then we rose to the challenge to improve practice in taking care of these extremely preterm infants. And so I'm even more thankful to my near peer mentor, Adam Bauer, and Nina Mendham, Ryan McAdams, my senior mentors who continue to support me each day in the fight for these nanocranies. A shout out also goes out to Igor and Katie for having the foresight and the courage to venture down this path with us and help us create a long overdue opportunity for our families. These are a list of my references. This is just a short list. There were several articles that went into this presentation, but these are some choice articles that I can share with anyone who'd like to see them about just periviable care. And that is my last slide. Thank you. Anyone is still awake, feel free to ask me some questions in the few minutes we have left.
Awesome. This was wonderful. I'll leave it over. We have a few minutes here for some questions if anyone has any.
Hi, Laura. It's Greg Bills. Can I ask a question?
Absolutely.
Wonderful talk. Thank you very much. I'm going to put you on the spot a little bit. This weekend I'm on call, and let's say a 22-week pregnant woman comes in with preterm labor breach with a cord prolapse. Heart tones are in the 60s. Is it reasonable for me to crash C-section that patient?
And does mom have any maternal indications for that C-section? Or do you have any concerns in this hypothetical scenario?
Well, she's got a 22-week baby that's, you know, about to die because of the cord prolapse, and we don't have much time to have a discussion about the effects of prematurity. I mean, it's going to be a snap decision, 22 weeks.
Well, so let me clarify. What I mean by that is, right, so when I ask, it's more about the maternal indication versus the fetal indication. And so is there something going on with mom? Is she a cardiac patient? Is there something where you're concerned about her health? But either way, the answer to that is you huddle with the neonatologist. The literature that's coming out of the University of Cincinnati and a few other choice articles that I've looked at say that at 22 weeks, it's going to be your call. It's going to be your decision to go ahead and provide cesarean delivery, as long as you have in some way, and I realize that in that instance, you don't have too much time to talk about classical C-sections, but as long as the mom is very clear on how you have to proceed with that C-section and the risk involved with that, then the current literature is suggesting that yes, you would proceed with the C-section if the family was in agreement and they wanted a full port press. They want resuscitation, they want everything for this baby. Does that answer
Okay.
the question or?
Thank you.
Absolutely.
Hi, this is Heidi Brown. I'm a urogynecologist. I don't deliver babies. I won't really put you on the spot. But I am curious about the implications. You didn't present a lot of data around morbidity. You presented a lot of survival data. So when I did obstetrics a long time ago, one of the big concerns was if the babies survived, what would their quality of life and function be like? Can you talk a little bit about how that's changed?
Yeah, no, that's an excellent question, and thank you for bringing that to my attention. I'm only coming out of this display just to see if I can quickly find the documents while I'm talking. And so, what we're finding is that certainly at the centers that have been doing things for quite some time, like this center Iowa that I'm referring to, rates of trach placement, rates of significant lung disease in adulthood, rates of significant IBH, all those are decreasing as care is standardized and as practice is standardized. And so it's not an easy journey or an easy feat by any means, but what we start to see over time after the mortality rates decrease is that these babies on an international and a national level, the morbidity is significantly decreased for a lot of these infants. And I was just looking to pull up an article from the University of Iowa about just some of their outcomes. But to answer your question in short, what we're finding is a lot of these infants nowadays have less morbidity. And so I'm going to pull up an article here. So I don't know if you guys can see this. Let me share my screen really quickly. Okay.
Can see it.
Let me know if you can see this article. Okay.
Yes, we can.
Okay, sounds good. And so this is data from the University of Iowa. And so to the question that was posed, right, we look at babies who are born at 22 to 23 weeks versus babies that are born at 24 to 25 weeks. And I mean, everything down the board from PDA, intraventricular hemorrhage, retinopathy of prematurity, periventricular leukomalacia, BPD, neck, tracheostomy, as I said, BP shunt, these numbers are starting to decrease. Again, we have to take this in context that this institution that I'm talking about is a leading authority in the care of extremely preterm infants, and so are countries like Japan and Sweden. But I think what we're talking about here is not if we should do this, but it was just a matter of when, right? And so we have to now start the process. And like I talked with the providers over at the University of Iowa, it was hard. It was hard 3 years ago when they started. There was moral distress. It was tough. But the opportunity will come to improve our care for these babies and decrease their mortality, not just their mortality, but also their morbidity. Does that answer the question?
Yes, thank you.
Can you hear
Thank
me
you
okay?
so much. I think we are out of time here.
Absolutely.
So we had a couple of resident questions, if we could have just a second for them.
Oh,
If we
sorry.
can-
Yeah. Go ahead. Yeah, I don't mind.
I think we can maybe have one question here, and then we got to go.
Okay, sorry, we tried to talk earlier, but I think there was an AV problem. I just had a quick question revisiting that UPH recommendation slide where you had said at 23 weeks, or at least the bottom kind of row, had been saying that there would be a recommendation if indicated at 23 weeks for a C-section. I guess my question kind of comes from this context of like increasing maternal morbidity and mortality in the US, and a lot of it being, related to surgical issues as well. And I guess what I'm kind of thinking about is at 23 weeks using that Von calculator, even in the best of scenarios, so at like an average EFW, a female singleton infant who got antenatal corticosteroids, there'd be a less than 50% chance of survival. And I think if we, C-section someone at 23 weeks, then, they have to have a C-section in the future. All their babies from there on out will be preterm. And I'm just kind of curious about whether or not this is something that is like in place now, or is this like a theoretical, this is something that may be coming out in the future in terms of recommendations?
So as far as for us, these recommendations are moving forward after meeting with some individuals from the maternal fetal medicine group and OB. We're moving forward with these recommendations. Now, they're not set in stone. Remember, this is not an opt-out thing, but more an opt-in to make sure that we hone our skills and improve. But I think when I talk about the hypothetical numbers that are center specific for this particular institution, that just shows that we haven't been doing it yet. I showed the mortality rates, over the last 5 years of 22 weekers that haven't survived. And so those numbers will change and they are improved in other centers. And so I think bottom line, what it boils down to is the parent and the family. If they decide that even knowing all of these risk factors and knowing the outcomes, because we will do a joint consultation and we will talk about these things extensively and give them the parent information sheet. If they decide that they've had, multiple pregnancy losses and incompetent cervix, and we talk to them about what life with severe neurodevelopmental impairment is, or we talk to them about what life with mild neurodevelopmental impairment is, and they say, I still want to proceed full court press, then it's more about offering this opportunity to them and less about, trying to pull back about our decision making in that process and giving them that shared decision making, making sure that they ask for what they need as a family and we can provide them that need as a family. Does that answer your question?
Yeah, I guess can't argue with patient autonomy. But that was pretty much my question, and just whether or not that had gone into the decision making regarding these recommendations. But it's helpful to understand that these are more of a opt-in kind of situation and not something that should be considered our standard practice right now, unless it's something that our patients specifically are requesting.
Yeah, and that's the key part of it, right? Like some of the data that I presented you, especially that 21 week or at 2 days, the youngest baby to live, that kid was from Wisconsin, but the parents drove up to Minnesota Children's because they know that they might not get that care here or at Milwaukee. And you have some moms and families that will drive up to Iowa. And or if they know they're going to be admitted here, say, oh no, I don't want to stay here. I want to. And so I feel as though, we are a group of young, amazing providers. If this is coming down the pipeline at centers all across the country, Indiana, Cincinnati, all these different places nationwide, Japan, then why not get ahead of this and work on improving our outcomes for these babies?
Thank you for your time. This was a really interesting presentation. We appreciate it.
Absolutely. Absolutely.
Yes, thank you so much for your time this morning and for presenting to us, and we really appreciate it. If anyone has any additional questions, if it's okay, we'll email those to you. And thank you again.
Absolutely. Thanks so much for having me.